Hello, and a very warm welcome to today's ISNTD Connect session. For those who are new to the series, my name is Marianne Comperet. I'm speaking from the International Society for Neglected Tropical Diseases. I'm tuning in from London, and it's my pleasure to welcome you all here today. For those who are familiar with the series, welcome back and hello. And it's my pleasure today to open up this session where we will be discussing scabies, learning and finding out all about the extent of the burden worldwide, but also not just control strategies, but actually an entire framework for control. Scabies was added to the list, the official list at the WHO of neglected tropical diseases about 4 years ago now. I think it's safe to say it is a very neglected issue. Some of you may be surprised to hear there are upwards of 200 million infections a year, and those infections carry many of the associated issues such as stigma, comorbidities, access to treatment, lots of the issues which are kind of pervasive among other NTDs as well. So a framework, a paper describing this framework for the control of scabies was published quite recently in PLOS NTDs. As you can imagine, a hugely collaborative effort with contributions from across universities across the world, from the UK, Australia, Senegal, Japan, Liberia, Philippines, just to name a few, but also at a higher, more official level from WHO Geneva, and also many of the regional offices across Western Pacific, Europe, Africa, and so forth. And it's our huge pleasure today to welcome Dr. Michael Marks to represent kind of this large body of collaborative work and also give us an introduction to scabies. For those who are kind of familiar with this sphere and in fact neglected tropical diseases as a whole, I think, Michael, you wouldn't need an introduction. Perhaps for those who are slightly new to the some of these topics that we'll be discussing today, I'll just remind everyone, Dr. Michael Marks, you are Associate Professor at the London School of Hygiene and Tropical Medicine. You're also an honorary consultant at the Hospital for Tropical Diseases here in London. And of relevance for today's talk particularly, you're also Vice Chair of the International Alliance for the Control of Scabies. So Michael, thank you for your time today. A very warm welcome. I hope you're doing well.
Yeah, thanks so much for the invitation.
Thanks so much for joining us. I know you've had a very busy schedule, so we're grateful you could slot this in. And without any further delay, I will hand over to you for a presentation. To all our attendees, I suppose you're familiar with this. Please don't hesitate throughout the presentation to post any of your questions or comments, anything you'd like to discuss in the chat function. If you could say hello with kind of your country or your organization, that's always really nice to know. So we've got here, just before I hand over, Michael, sorry, just a quick hello to Mohammed Jemli, Emmanuel Nadi, Milena Simic, Robert Kulbunders, Maxwell Mahari, just to name a few who've tuned in today. Lovely to see you all. And so over to you, Michael, and a very warm welcome to all. Thanks a lot.
Great. Well, thank you very much, everyone, for joining and for the invitation to speak. So, as Marianne mentioned, my name is Michael Marks. I'm an epidemiologist at the London School of Hygiene and Tropical Medicine, and I am the current Vice Chair of the International Alliance for the Control of Scabies, which is an organisation bringing together academics and other partners with a sort of shared interest in the global agenda of scabies control. So just outlining what I'm going to talk about today, I'm going to cover two pieces of, or two sections, background, a sort of introduction to the concept of scabies as a public health problem. I'm sure that everyone is familiar with the idea of scabies as an individual unpleasant skin condition, but really moving from that idea of the individual to the population level, and reviewing some of the epidemiology and the data around potential control strategies, and then moving on to the sort of components that are making up the proposed new framework for scabies control moving forward. And this is obviously situated by and in and informed by the new NTD roadmap for 2021 to 2030, and a number of other developments in diagnostics and medicines that have led on to this WHO informal consultation and eventual proposed framework. So starting just with a brief introduction to the concept of scabies as a public health problem. I'm sure that you are all familiar, or I hope many of you are familiar with the idea that scabies is caused by transmission of a parasitic mite, and really in highly endemic settings, transmission is almost exclusively human-to-human transmission by prolonged skin-to-skin contact. And on the left, you can see a female mite moving around slowly, and the life cycle is that the mites burrow under the skin, the male and the females mate. The female will lay eggs, which will hatch over a period of time before maturing, and then the cycle will continue. And that's important because itch, which we think of as one of the major features of scabies, is not actually caused by the mites themselves, but by their excreta and their eggs. So people often don't become itchy immediately upon infection, but it takes some time. And secondly, because the drugs that we have available to treat scabies are differentially effective at different stages of the life cycle. And at the moment, at least, that has important implications for control strategies. So we want to think about, why people should care about scabies as a neglected tropical disease and why it matters. And this is a schema from a paper that IACS and partners published in Lancet in 2019, really trying to lay this pathway out. So we have, on the left-hand side, the primary effects of scabies itself. So it causes skin lesions, which are stigmatizing and are very itchy. And that results in stigma, social isolation, sleep disturbance, and associated with absenteeism from education, economic effects. So many of the sort of primary manifestations that we see with a number of the neglected tropical diseases. So this is a disease here with significant morbidity, and it's morbidity that is reaching out beyond the direct health sphere into other aspects of people's mental well-being and their educational and financial well-being. And that, I think, in and of itself is something that warrants intervention. But really for scabies, because infestation with scabies results in breach of skin barrier function and modulation of the local host immune response, there are a number of downstream sequelae that follow from the initial infestation. And most importantly, there is a significantly increased risk of impetigo, or pyoderma as it's sometimes referred to. So these are superficial skin infections, most commonly caused by Streptococcus pyogenes and Staphylococcus aureus. And you can see here typical examples of someone who's got secondarily infected scabies lesions. And in many parts of the world, scabies is one of the, if not the predominant driver of impetigo. And through this is adding additional morbidity, health impact, requirement for additional treatment. And so this is a sort of super added impact beyond the direct effects of scabies itself. And then moving on from that further, through this increased risk of skin and soft tissue infections, patients are at a higher rate of more serious infections. So previously I've shown just impetigo, these are superficial infections, but we know that those in and of themselves predispose to more severe skin and soft tissue infections, such as cellulitis or necrotizing fasciitis, to bloodstream infections with Streptococcus and with Staphylococcus, which have high mortality rates. And Streptococcus pyogenes is associated with a number of downstream immune-mediated complications. So these are caused by an abnormal host immune response to the bacteria, which can result in kidney damage, resulting in chronic renal failure, and can contribute, we believe, to rheumatic fever, leading on to rheumatic heart disease. And both of these diseases, rheumatic heart disease and chronic kidney disease, have considerable mortality rates per year and a huge economic cost of treatment. So really we see a spectrum of effects for scabies, varying from the direct manifestations of the scabies infestation itself through to the secondary effects of additional bacterial superadded infection, and through to the downstream consequences of those. And these are really quite significant. You know, there are estimated to be several 100,000 deaths a year from rheumatic heart disease. So even if scabies is only contributing to a small proportion of those, that is a significant mortality impact, as well as its considerable morbidity impact. And we know that scabies has an extremely high prevalence in many countries, but really compared to a number of the other neglected tropical diseases, you'll see that data remains very limited. So this map shows a range of countries where reasonable quality prevalence surveys have been undertaken. And if I draw your eye in the first instance to the bottom right corner, you'll see that a number of the Pacific Island countries, so the Solomon Islands, Vanuatu, Fiji, Timor-Leste, for example, they all report general population prevalences of more than 20%. So these are extremely high prevalences in children, really. You know, 1 in 4, 1 in 5, often in these contexts, having scabies infestation, and can be higher in the highest risk groups. And you'll see that similarly high rates of infestation have been reported in a number of countries, several parts of Latin America, and across Africa. But really you see that there's a great dearth of information reflecting the fact that good quality prevalence data is lacking and is a clear programmatic need. Excuse me. I think the real sort of progress over the last 7 or 8 years has been in the development of community-based control strategies. And these will be familiar to many of you from other neglected tropical disease programs. So this is what we refer to as mass drug administration. And you know, this has been a mainstay of programs for many NTDs, including trachoma, onchocerciasis, for example. And ivermectin is a highly effective anti-scabies drug. And so people, including our group and collaborators, have been undertaking a series of studies to understand how ivermectin-based mass drug administration can be used to control scabies. And I'll just take people through a bit of that data. But really the headline figures, you know, in studies are that in high prevalence settings, a single round of mass drug administration appears to be able to reduce the prevalence of scabies by up to 90%. And by reducing the rate of scabies, it also reduces the prevalence of these secondary bacterial infections. And I think that's a particularly important point, because it's reducing the burden of these bacterial infections without having to use antibiotics. So that is both good in terms of reducing our exposure to antibiotics, and it also shows that that relationship between scabies and impetigo is very clearly causal, because reducing scabies does translate truly to a reduction in impetigo. And I'm just going to highlight from 2 of the major studies. The first, which was a study called SHIFT, the Skin Health Intervention Fiji trial. And in SHIFT, 3 communities in Fiji were randomized to 3 different interventions. An ivermectin-based mass drug administration arm, permethrin, which is a topical anti-scabies treatment arm, and what the study team referred to as a standard arm. And I'll just explain a little bit about the standard arm, which will explain why the standard control arm seems to have such a profound effect. Because this was a trial, it was felt unethical in the context of the study to have a true control arm where people had the prevalence of scabies measured at baseline and again at 12 months and again at 24 months. It was felt not ethical to diagnose people with a treatable infectious disease and leave them just so you could see what happens. And so the standard arm in this study consisted of examining every single person in the community, diagnosing every person in the community who had scabies, providing them with a referral to their local health clinic, and ensuring that the local health clinic was already stocked with appropriate drugs. So I think we can all agree that that is probably quite distant from the actual reality of what would have happened if the study hadn't taken place, and probably explains why there was a reduction in the standard arm. Notwithstanding, there are several striking findings. You'll see that at baseline in this study, all of the communities had very high prevalences of scabies, between 30 and 40%. So this is an incredibly common condition in some of these communities in Fiji. And it's very clear that the ivermectin-based strategy is the most effective, reducing the prevalence of scabies from more than 30% to only 2% at 12 months. And no other interventions were delivered. So there were no environmental measures taken, no cleaning of bedclothes or personal clothes or possessions, which are often recommended, and no further mass drug administration was carried out. And despite that, you can see that the prevalence of scabies remained really low, 3.7% out to 24 months. And as I've mentioned, you can see here on the right that just by treating scabies, there was also a significant onward reduction in impetigo. So this was really the first study to establish ivermectin-based MDA as the standard of care, and we followed that with a larger study in the Solomon Islands involving 25,000 individuals, but where broadly you will see the findings are very similar. Scabies was very common at baseline, almost 1 in 5 individuals had scabies, and it fell to only 2% at 12 months. And again, no other interventions were delivered. And although you see a slow rebound up to just under 5% at 36 months, this means still 3 years after 1 round of MDA, the prevalence of scabies was still only about 20% of what it had been at baseline. So really demonstrating that high coverage MDA in areas with not much population movement can be highly effective. And again, we see a significant and sustained reduction in secondary bacterial infections. So really, those are some of the data that have underpinned this work in bringing together a framework for scabies control, which I am going to move on to now. So first of all, you can see this slide is slightly out of date because the WHO NTD roadmap is very much no longer in draft, but is published. And as Marianne mentioned, scabies was one of the newly added NTDs since the last roadmap. And therefore, for the first time, there is indicators and targets for scabies included in this roadmap. And there are 2 major targets that have been adopted. The first is about countries incorporating a scabies management plan within the universal healthcare package. And you can see that this aims to scale up between 2020 and 2030 to reaching global coverage. And then a second goal, which is around the proportion of countries or the number of countries where MDA is rolled out as a control strategy for scabies. And obviously this is a lower number, both because this is a significantly larger undertaking and also because there will be many countries where MDA would not be the appropriate strategy. And so this is really focused on those countries such as those in the Pacific and in other parts of lower middle income country settings where the prevalence is particularly high and where MDA is felt likely to be the appropriate strategy. And there are therefore a number of critical actions that are required around guidance and tools for mapping in endemic countries, guidance for the implementation of preventative chemotherapy, which is how WHO refers to MDA, and creating the advocacy and funding plans that are required to move this forward. So there have been a number of steps taken to drive this forward, one of which has been the development by IACS of consensus criteria for scabies diagnosis. And the idea here has been to standardize the way that health systems, particularly in lower middle income countries, evaluate and make a diagnosis of scabies so that we can begin to move towards standardized diagnostic criteria, standardized surveys, and standardized estimates assessments of the impact of MDA. And so this has been a really useful development, and is beginning to be taken up by many groups worldwide. And there is essentially a structure that ranges from suspected scabies all the way up to confirmed scabies, and a sort of recognition that confirmed scabies, the sort of highest level of specificity, is really designed for use in high income settings and in potentially drug trials, whereas the lower levels B and C are really what we anticipate being used in surveys by non-expert examiners in the field. And IACS has developed a series of tools to help people begin to convert these criteria into actions as part of this framework. Another really important step has been the addition of ivermectin to the WHO essential medicines list. Ivermectin already was on the WHO essential medicines list, but for different indications. So, for example, for onchocerciasis and for lymphatic filariasis. But thanks to the work of colleagues at the International League for Dermatological Societies and the International Foundation for Dermatology, and we were able to get ivermectin added as a medicine for specifically the treatment of scabies. And that is important because that plays a role in allowing or assisting countries in accessing ivermectin for this specific indication, which differs from the indications that it has traditionally been used for in the context of NTD programs. And so coming towards the end of the sort of presentation component, all of these components which feed together into the development of a framework for scabies control. And so in 2019, the World Health Organization held the first informal consultation on a framework for scabies control. And this was held in Manila over a number of days and attended by experts from academia, from NTD programs, from the task force, from WHO regional and HQ offices, and really to try and move forward with some provisional steps, recognizing that there are still a large number of unknowns, and we are still trying to learn what the right approach will be in different settings, but giving us an initial framework that we can work within. And so we try to tackle these around those critical areas that the WHO roadmap had identified would be necessary to move forward for scabies control. And so on mapping, really an attempt to stratify this into a number of steps. So identifying potential areas for MDA, which might be based on pre-existing data or desk review, to at least prioritize which countries and which districts within countries were most suspected to have a higher burden of scabies and therefore be targeted earlier. And really, the proposal is to use rapid clinical assessments using trained health workers, but clearly not dermatologists. So using simplified clinical case definitions based off the IACS criteria and limited exposure. So if you're diagnosing a patient with scabies in your clinic as an individual, it's really important to know absolutely for each person, do they have scabies, yes or no? And therefore, potentially examining their whole body is very important. But here we are trying to make decisions at the population level. So the precise diagnosis for each individual becomes less important than understanding, is the prevalence 2%, 5%, 15%? And secondly, of course, we want something that can actually be actioned and made operational. And so there's really been a lot of work done thinking about limited exposure examinations, by which we mean just examining the exposed limbs and the head and neck. And there have been a number of evaluations of that now conducted in both sub-Saharan Africa and the Pacific, showing that that remains a highly effective strategy, really very sensitive for picking up scabies. And based on the current data, the idea is to do community-based, all-age surveys. And of course, there may be opportunities to consider other strategies like school-based surveys, but there's a recognition, at least for the moment in the framework, that most of the data is based on whole community-based evaluations. And so that's the idea of what do you need to do to get going, rapid mapping, and then we may want to embed some more accurate, more detailed prevalence surveys as part of our impact assessments. And these are important, for example, to do impact assessments through longitudinal monitoring, but also so that we can potentially get, where appropriate, age and gender specific disaggregated estimates of burden and impact, so that we can see that our programs, as we develop and roll them out, are reaching everyone equitably. So what about actually implementing MDA, which was the second of the critical actions that WHO identified? And the consensus in the provisional framework is that mass drug administration would be an appropriate strategy where the community prevalence is at least 10%. And I think everyone in the community acknowledges that this is somewhat an arbitrary threshold, but it was one at which experts felt that there was sufficient evidence for the use of MDA. And based on the data I've shown you, the current feeling is that this should be utilizing an ivermectin-based regime, currently using 2 doses of ivermectin 7 to 14 days apart, reflecting, as I mentioned, the fact that the drugs don't necessarily affect all components of the life cycle. And there are a number of ongoing studies which are close to reporting to see whether or not we could simplify this to a single dose of ivermectin, which would obviously at an operational level be extremely attractive. The feeling was that this should be implemented at a fairly high level, so the district level. And as with many programs, that's both because that's logistically easier, but also because there are risks that if you're treating on a very small level, you will get movement between treated and untreated communities, which may result in reintroduction of scabies into untreated areas. So the idea is to try and reduce that risk as much as possible. And we are aiming to treat as much of the population as possible. And the recommendation, at least in the provisional framework, is that we should be doing annual MDA for a certain number of rounds and continuing after that to evaluate the impact and stopping if the prevalence is below 2%. And just as with the 10% starting threshold, I think we all acknowledge that this 2% stopping threshold is arbitrary at the moment and requires further both empiric and other sources of data, health economic evaluations, really to understand how we will best move this forward. Where the prevalence is very clearly low, below 2%, the feeling was that the best strategy at the moment, for which there was the most evidence, was an intensified disease management strategy. So that's about ensuring high quality diagnosis at facilities, access to an appropriate scabicidal treatment, and appropriate treatment of patients' contacts to reduce their risk of reinfestation, and that this should be linked to and delivered through WHO's Universal Health Coverage Initiative, so making the treatment of scabies a key component of UHC. And I've identified here a number of the steps that will be required, so enhancing clinical care in primary health, developing appropriate guidelines, training, and improving the general quality of data collection. And then we have a sort of grey area at the moment, which is where the prevalence is more than 2%, so substantial, but below 10%, the threshold at which currently MDA is appropriate. And there's really felt to be limited data at the moment to guide a strategy here. And so there would be flexibility here for local actors to make decisions about what the appropriate strategy might be. And it may be in some settings that MDA was still considered a completely reasonable strategy in this context, because empirically, it doesn't feel like there would be a significantly difference between 9%, for example, and 10%. But as with all of these things, you have to draw a line at some point, and the line currently has been drawn at 10%. I'm not going to go through all of these points now, but there are a number of key programmatic research issues that were identified, and they're outlined both in our paper in The Lancet in 2019 and in World Health Organization's report of the informal consultation. I'll just highlight a few of the very key ones. which include the fact that we need more studies to determine the impact of MDA and scabies control strategies outside of islands, and particular in urban settings, because scabies is relatively unusual amongst the NTDs in that it's also prevalent in urban settings. To better understand this relationship between scabies and impetigo, because that has big impacts on the sort of value added of treating scabies. To move forward in really defining these sampling methodologies for programs. And many of you may know that ivermectin is not currently used in children aged under 5 years or under 15 kilos, but there are a number of studies going on to investigate if it may be safe to do so, which would significantly simplify treatment regimes. So in conclusion, there have been really considerable progress on control strategies for scabies over the last few years, and it's very encouraging to see these targets in the new 2021 to 2030 NTD roadmap. But we really need ongoing operational research and partnerships with ministries of health to drive forward the control of scabies globally. So I'm going to finish there, and I'll just mention that IACS have our annual meetings coming up later in October and November. There are 2 meetings. You can find details of them on the IACS website. You'll see that one of them is at a very unsociable time if you're based in the UK, but a very sociable time if you're based in the Pacific. And one of them is based at is a fairly unsociable time if you're in the Pacific, but a sociable time if you're in a European or African time zone. So I hope if many of you are interested, you may register to attend these meetings and learn more about what has been going on. So with that, I'm going to finish, and I'd be happy to take any questions going forward.
Thank you very much, Michael. Those dates have been firmly put in the calendar. I'm sure lots of our colleagues and attendees would love to follow up with you. The presentation was very inspiring and actually in complete contrast to the horror that is a scabies infection, as you interestingly highlighted, not just at the individual level, but also as a public health problem. So in complete contrast to that, it's been very encouraging and inspiring, actually, to see how far this control framework has come from the advocacy level to the access to treatment, getting ivermectin on the essential diagnostic list, kind of on many levels. I certainly, and I'm sure our attendees do as well, leave this presentation feeling very optimistic. And I suppose that's where perhaps the first question we could start there is, are you very optimistic about the control of scabies on a global kind of level? And within that, what do you feel might be some of the main challenges that you might face? You've listed a few, but which one do you feel might be most difficult to overcome?
I think overall, I think I'm moderately optimistic. I think, we've made quite a lot of progress in the last 5 to 10 years. I think the major challenge for taking scabies programs to scale is drug supply. So for the onchocerciasis and the lymphatic filariasis programs, those are very kindly supported by free donations of ivermectin by Merck. And currently there is no drug donation to support scabies programs. So although there are a number of fairly affordable generic good quality manufacturers of ivermectin, it's a considerable cost burden to buy ivermectin at the sort of scale that you're talking about for programmatic implementation. And so obviously that's very different from all of the major mass drug administration NTDs, trachoma, STH, schistosomiasis, onco, LF. They are all supported by drug donation programs. And I think procuring reliable, large enough, cheap enough supply of ivermectin is probably the major barrier facing programs at the moment.
That's really interesting. So that message has been heard loud and clear, I hope, throughout our networks. While you were explaining this, there have been a few thank yous from our attendees. Majid Fasihi Harandi, Professor Harandi from Iran, is saying, thanks, Dr. Marks, for this brief but comprehensive, nice presentation. Dr. Major Dillon, thank you, and very informative webinar. Scabies has truly been neglected by public health officials. But on the positive side, Dr. Betty Nabate has joined us. Betty is from the ISNTD health authorities in Uganda. And Betty writes, I have been party to community surveys for LF and schistosomiasis. I have observed high burdens of scabies in almost all the districts that stopped MDA. I would be happy to work with anyone interested to work in Uganda. We're also currently updating our NTD master plan, and I'd be happy to get more information to do advocacy. So I think you've inspired already at least a few of our attendees to further this, the advocacy for scabies. Do you find that in terms, going back to this notion of advocacy, I mean, scabies has the benefit that it is one of the NTDs that perhaps people in non-endemic regions may actually have heard of, unlike some of the other NTDs. Is that something that you feel could be a real benefit, and is that something you could leverage?
Yeah, so it's certainly true that obviously scabies is found everywhere in the world. It has certainly, I think, made, if you look at the map that I showed, and you know, there's a lot of good quality data from the Pacific, and that's where nearly all the most recent large-scale studies have been done. And that is because the Australian government puts quite a lot of money into scabies, and that undoubtedly reflects the fact that scabies is quite common in the Indigenous Australian population. So scabies prevalence is reported in, you know, Indigenous Australian populations in Northern Territory, often of 20, 30, 40, 50%. And similarly, you know, quite high amongst some Maori populations in New Zealand. And so certainly with those national governments, it has made scabies be on the agenda because it's a problem for their own communities, and that has translated into a substantial research base there and extending out into the region. I think, you know, it is obviously helpful that people are familiar with scabies. I think the difficulty is that for most people it is probably felt to be a fairly, I mean, irritating, but minor inconvenience of an infection. But I think the situation in settings where, you know, 1 in 5 people have scabies is quite different from, you know, where you might meet one person in your life who's got scabies. And all of those sort of downstream complications, infections, immune-mediated complications, you know, they're not really things that people see in high-income settings. So I don't think it hurts, but it's probably outside of the fact that the Australian government use it as a rationale to provide funding. It's not yet translated into a clear sort of advocacy win.
Fantastic. There was a question here from Ana Garcia Mingo, who's sending her greetings from Spain. So nice to listen to you, Michael. I would like to know if there are any working groups in South America.
Lovely to hear from you, Anna. Anna was awarded the first Royal Society Tropical Medicine and Hygiene and International Alliance for the Control of Scabies joint small grant this year, which I think she'll be talking about at one of the IACS webinars. So you're right that I haven't really talked much about Latin America. Some of the most important original work done in the sort of late 80s through to 1990s was done in Panama. So there is a sort of tradition of that work in Latin America. We have been in regular contact with PAHO, so that's the WHO regional office for the Americas, and we hope that in early 2022 we'll be working with them to put on a series of online events to bring together stakeholders interested in all neglected tropical diseases involving the skin, which obviously will include a large focus on scabies, but also, for example, in that region of the world, leprosy, chromoblastomycosis, tungiasis. So there are moves afoot in that direction. And I think sort of linking Anna's comment to the one that Betty made, you know, I think there is a general concern that where onchocerciasis programs have finished, that the prevalence of scabies may well go back up because those communities were previously receiving regular ivermectin for their onchocerciasis control. And so Latin America, for example, where onchocerciasis has been effectively eliminated apart from a very small region, you know, will we see rebounds in scabies now that ivermectin, even if it wasn't being used for scabies, may have been indirectly helping control the problem. So it's an important area.
Thank you very much. In terms of overlaps in MDA programs, there was a question earlier on in the chat. I think it was referencing specifically lymphatic filariasis MDAs, or integrated disease management. I'll be perfectly honest with you. I have a crazy cat who disconnected me at that moment, so the question has been lost on my side. So to our attendee who posed the question, if you would like to repost it.
I can see the question.
You can see the question. Okay.
It's a great question. To what extent ivermectin containing mass drug administration regimes not delivered for scabies have an impact on scabies? They probably do have some impact, but I think that there are several differences which mean that they are very unlikely to be sufficient in and of themselves. The first is, at least as far as we're currently concerned, you need to deliver 2 doses of ivermectin for a scabies control program, whereas an LF program or an onchocerciasis program only delivers a single dose. So that's one difference which may be important. I think the more notable difference is that although in scabies, and you'll have heard, you know, I don't say ivermectin MDA, I say ivermectin-based MDA, because approximately 15% of the population in any setting will be not eligible for ivermectin because they're a child under 5 years or 15 kilos, or they're pregnant, or they're breastfeeding. And in an onchocerciasis program or an LF program, we don't treat those individuals, because as long as you treat the rest of the population, you can interfere with the transmission of LF or onchocerciasis. So you can still achieve control even by not treating children in that age group. But that's not effective for scabies, because the highest burden of disease is in children aged under 5. So in a scabies-based MDA, we provide permethrin cream, topical cream, for those individuals. So there's quite a large difference between the population that are treated for an LF program and a scabies program. You know, you're missing 1 in 5 people in an LF program, and you're probably missing the highest risk 1 in 5. And that's another reason why work to bring down the age or the weight at which ivermectin-based regimes can be used would be valuable, because you know, although we do deliver ivermectin and permethrin, it would be much easier if programs could just say give ivermectin all the way down to 2 and only have to give permethrin to a much smaller proportion of people. So that is that's, I guess, an explanation of why I think LF and onco programs are probably not as effective as people might hope them to be for the control of scabies, and how we might move forward addressing that.
Thank you. We just have a message here from Ronaldo Cavalho-Scholte. Thanks for the informative presentation, Dr. Marks. Scabies is indeed very neglected, and as you pointed, the burden is unclear in the Latin American and the Caribbean region. We will soon plan a regional meeting together with IACS. And Ronaldo Scholte is with PAHO and WHO. So some very positive news there. Fantastic. And a really interesting question, looking at the diagnosis by Arlene Bertuso. Hello, Arlene. Confirmatory diagnosis of scabies is through finding the mites, and this procedure is invasive. Is there a method which you can recommend that will not scare children or parents?
So you're right that on one level, the sort of gold standard diagnosis for scabies is direct visualization, which there are a number of methods that can be done. Traditionally, using a needle, for example, to extract a mite and then visualize it, which is not pleasant. Dermatoscopy is a non-invasive direct visualization technique, but you you need to be a dermatologist really to be able to do it. And the reality is that all of those direct visualization methods are not really suitable for use in programs. And that's for several reasons. One, they're invasive. Two, they require highly skilled training, which you can't easily roll out. And three, they're not actually that sensitive. So they're highly specific. You're unlikely to be wrong. If you see a mite, the person really does have scabies, but not everyone who has scabies will you be able to find a mite with a microscope or with a needle. We know, for example, from some nice work my colleague Steve Walker and colleagues in Brighton did, so Steve is a consultant dermatologist at Hospital for Tropical Diseases, a sort of authority on the clinical diagnosis. And he spent 30 minutes examining each patient in a study. And of all the people that had scabies, he could only find with a dermatoscope 40 to 50% positivity rate. So it's not an adequate test. And so that is why the IACS Delphi criteria are really focused around clinical diagnosis and not at all around the use of invasive testing. So for programs, we're not recommending any of the invasive tests. We're recommending use of standardized diagnostic clinical criteria, so that is more straightforward.
That's really interesting and ties in quite nicely to a question by Mohammed Habib Jemli. Mohammed saying, thank you, Dr. Marks, for this beautiful presentation. And Mohammed has actually got 3 questions, so I'll just take them in reverse order. Back to, as you were saying, the inapparent forms. Mohammed's asking, what serological tests are there to detect inapparent forms?
So currently there are no good serological tests available.
Okay, that's so food for thought there. Another question from Mohammed. So what are the side effects of ivermectin in humans? I suppose that's kind of a slightly broader question.
Yeah, so ivermectin is a very safe drug. It's probably one of the most administered drugs in the world because of its use from onchocerciasis and LF programs. Probably several hundred million people a year take ivermectin. And in the context of sort of single dose treatment, side effects are mild and self-limiting. So headache, dizziness, upset stomach, none of which are normally last more than 24, 36 hours. So it's really a very safe drug.
Fantastic. And actually, this is a very good point, kind of opening up the discussions to a One Health element. Have you encountered any form of zoonosis, mange? And is that something that should be of concern?
Yeah. So there are related mites that infect animals and cause mange. They are not important sources of transmission to humans. Okay. So the human scabies is caused by Sarcoptes scabii var hominis, and in endemic communities, transmission is from person to person of human mites, and we know that from sort of basic biology, but also, when we do studies of mass drug administration, we don't do anything with any of the animals or any of the bed sheets or any of those things. We just treat the humans. And so if animals were an important source of infection back to humans and you left them all untreated, you would expect that that would cause the scabies numbers to go back up, and it doesn't. So we're really very confident that in these sort of contexts where 10, 20, 30% of people have scabies, that it's really humans who are the reservoir, and it's human to human transmission that is the sort of driving force.
Wonderful. And I just going back to the ivermectin question, I hope Milena Simic, I hope that has answered your question, which was what are the side effects of ivermectin? And I'm a little bit late in seeing Arlene's reply, which was just saying, thank you very much for the answer, Dr. Marks. So we, Michael has just been disconnected shortly, but that's perfect. Gives me a moment to look at some other questions. There we go. Hi, Michael. You're
Sorry,
back.
I don't know what happened there.
Maybe my cat just jumped over to yours and chewed the wires there. Roleo Emmanuel's asking here, can resistant scabies breakout be removed surgically to get relief from the terrible itch?
So I don't think there's any role for surgery in the treatment of scabies. I mean, individuals who have crusted scabies, which is a particularly severe form of scabies, they do need more treatment than the the regimes that I'm describing, which are for the treatment of what we would call common scabies. And so certainly individuals with crusted scabies who are often immunocompromised, they often require multiple doses combining both topical and oral therapy. And in terms of, I guess, drug resistance, there are only 2 well-described cases of resistance to ivermectin, and they're both in the context of individuals who had crusted scabies and had received very large numbers of doses. So we really don't think that drug resistance is in 99.9999% of cases, we don't think it's a clinically important feature, and there's certainly no role for surgery in the treatment of scabies.
Okay, very interesting. And that kind of goes part the way to answering Betty Nabate's question, which is, have we thought about resistance to ivermectin, especially in communities that have been taking it for over 10 years? I guess you sort of answered that point just a few seconds ago. And just to note that Roleo Emmanuel has kindly shared that scabies is truly neglected. Roleo suffers from scabies, which has been suppressed with a topical treatment, but is still terribly itchy with each breakout. Perhaps you would both be able to discuss this at further length, but Roleo, you end your comment with "what a neglect!" exclamation mark. So definitely we hear you loud and clear there. There was just a very technical question, sorry, from Milena Simic. Could you explain the ivermectin dose? So quite a technical question there in detail. I suppose it depends.
Yep, so there's a standard dosing regime that's used, which you'll find in, I mean, one should look at what is recommended in the country that one works, what a national program licenses. In our trials, we use a dose of 200 micrograms per kilogram, but the drug comes in 3 milligram tablets, so it gets rounded to the nearest 3 milligram tablet. But yeah, so that's the sort of fairly standard dosing that you'll see described in a number of papers. People have tried slightly lower dose, so that's very slightly more than is used for onchocerciasis or lymphatic filariasis, and less than is being used for some other indications.
Thank you. I suppose there's been thinking about whether scabies could be integrated into existing NTD control programs, but Majid Fasihi Harandi here asks, or rather says, perhaps conversely, we could integrate other NTDs to scabies control plans, or even perhaps other skin conditions. Do you see kind of natural alliances there that could be leveraged?
So certainly in the 2021-2030 roadmap, WHO has put considerable effort into the idea of the development of integrated skin NTD programs. That's an area of my interest, and that integration may be at different levels. It might be in mapping, it might be at management at the primary healthcare level, it may be in the management of disability or morbidity. For example, the morbidity management of podoconiosis could be combined with the morbidity management of lymphatic filariasis, or the wound and ulcer care of leprosy could be combined with the wound and ulcer care of many other skin entities. So that is certainly, that integration across diseases is very much a theme of the new WHO roadmap. And I think, an area of open research, well, an area that would benefit from research would be, what would be required to transform an LF program or an onco program into a scabies program. I've mentioned some of the reasons why I don't think, as they currently exist, LF or onco programs will be effective scabies control programs, but could they be meaningfully converted into those to allow integration? So I think there are definitely opportunities for integration both with MDA programs and with other skin diseases.
Dr. Marks, we're coming towards the end of the webinar. You've answered many of our questions. I suppose I was going to end just to ask, this is a very international, multidisciplinary audience here, and perhaps if you had any final thoughts on what next steps could be, or what you would like to see this audience kind of do to advance not just the advocacy, but also on a practical level, those partnerships needed for scabies control.
Yeah, so IACS for certain is looking to improve our reach out of our existing network. So if you're interested in that, reach out to me or through the IACS portal. I'd be delighted to talk to you about the meetings that are coming up and the other ways that you can contribute to the society. Certainly, we're very keen to extend that. So please do get in touch.
Fantastic. Well, I'm sure the attendees would all agree with me in saying that this has been a really eye-opening session and also a very encouraging one, very positive. The foundation of all this work is already hugely collaborative, hugely international, driven on partnerships. So we very much look forward to watching the next steps. I hope everyone's put the dates of the meetings in their diary. And also definitely get in touch, as Michael just said, through the portal to explore any possible collaborations. So Thomas Ashiri is saying here, thanks, Dr. Marks, for a good presentation. I wish all a good implementation. Absolutely. A thumbs up from Releo Emmanuel, and from us all here, a very big thank you to you, Dr. Michael Marks, and thank you to everyone who tuned in today. We look forward to seeing you all next week. And in the meantime, I wish you all very well and keep safe, and see you next week. Thank you, Michael.
Take care.
Thank you. Take care. All the best. Bye, everyone.